This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.
My name is Joe Sam Robinson, and I'm pleased to have with me as my guest tonight Dr. Sammy Walid, who is the Director of Research at the Georgia Neurosurgical Institute. Well, there are a lot of things that we've talked about on our show. Some of them have had a medical connection. Some of them have had more of a social issues. And tonight we're going to talk about something that often has a very tragic patina attached to it, and that's brain tumors. Mm-hmm. Now, we often, as neurosurgeons, have to unfortunately deal with this problem. And I think it would be useful tonight maybe just to give a general discussion of this problem. If many people have had relatives or friends that have had this difficulty, and sometimes the situation is curable and sometimes it's not. It's a very big and broad subject. And we're only going to hit on a few points tonight, but I think it might be a useful exercise to do this. I mean, it's not a common point of discussion. I mean, in the general among the general population, and maybe one doesn't hear much on television about this. But we're going to see what we can do tonight. And right. Nice to have you with me tonight, Dr. Walid. But let's start out with our first slide. We'll just take a little picture here, a little comment on brain tumors. So we're going to show our very first one after this, which I hope will be, there we go. Now, I hope this is not overwhelming for our audience, but this is the most complicated form that matter can assume in the universe, and that's the human brain. It's a extraordinary organ. It weighs not a lot, anywhere from 6 to 8 pounds. Sometimes in some people, Sammy, it weighs less. Yes. But it's a little joke here. But it does extraordinary.
Most important is density.
It does extraordinary things, and this is the way it looks. But we don't really get a sense of its majesty until we look at the extraordinary circuits that take impulses from different parts of the brain. So it enables us to have our cognition, to write great music, to produce great art, to do great things, to do noble things, to help people, I guess, to love, to climb mountains. So it's a really extraordinary organ, and it's divided into many into different sections here. They communicate with one another. And unfortunately, this organ is susceptible, as all our organs are, to developing cancer. And we're going to talk a little bit about it, and we'll start out with our next slide just to make a few comments about the brain. Now, I hope this is not too tedious for our general audience, but I'm going to talk a little bit about some of the important physiological special qualities of the central nervous system that have an impact on the body as it responds to brain tumors. And there's something here that we can see on our slide called the blood-brain barrier. And I hope I won't be too tedious, but there's something that God did with our brain that's very, very special. And it did not allow random molecules to get in the brain. So the brain is a protected organ. The substances that are in the blood do not routinely make their way into the brain. There's a barrier there. The cells that encompass capillaries in the brain have so-called tight junctions, so nothing can get into the brain that God did not want to get in. There's also a diminution of pinocytosis, which is a way that these cells take substances into the brain. So it's a very special barrier that allows the brain to function as it needs to. The brain is a low-grade electronic battery. There's an electric current in the brain. The brain is sending electric currents and impulses through it 24 hours a day. And to maintain that electric current and to maintain a healthy brain, this blood-brain barrier has to exist. And when a brain tumor occurs, this blood-brain barrier is violated. So that's a really important physiological fact that I'll talk about. That's number one. So understanding brain tumors, the blood-brain barrier is violated by the brain tumor. Right, our next slide. Another big thing that's special about the brain from any other organ is that when blood goes into the brain, there's a special system of autoregulation so that the blood vessels in the brain constrict if there's an excessive amount of blood pressure and dilate when there's not enough blood pressure. So what that does, it enables the brain to just get exactly the correct amount of blood and therefore be able to function. And once again, in brain tumors, when this autoregulation is impaired, we have all kinds of problems, and that's what the brain tumors do. All right, our next slide here. So we're just going to, this is kind of a schematic drawing of what occurs in the presence of these brain tumors, and it's a biochemical event that causes this vasodilation and constriction. So we see this happening. The cells that surround these blood vessels are called astrocytes, and they're reparative cells that are sort of the handmaidens of the neurons inside the brain, and they participate in this autoregulation event. Next slide. So I'm going to talk just a little bit about different kinds of brain tumors, and I think possibly some people in the audience might have encountered these lesions. I'm going to talk about there are all kinds of different kinds of brain tumors. I'm just going to mention a few that are quite common. The first one are called meningiomas, and these brain tumors arise from the meninges, and that's the structure that surrounds the brain. The dura is part of the meninges. It's sort of the supportive connective tissue upon which the brain rests. And sometimes the supportive cells can start to abnormally grow, and as these cells grow, they push into the brain. This is particularly common in females, and I think an important thing to be said about these lesions are generally what we would call benign, in that they don't metastasize, they don't go anywhere else. They can cause difficulties if they push against eloquent neuronal tissue. They sometimes cause seizures. If they grow and cause problems and cause brain swelling, then we operate on them and take them out. But they can frequently be followed. And Sammy, I would say an older person such as myself, I know you're a young guy here, but we're more likely to have them. And there are many older people that have these lesions, and it's often not necessary to do anything to them. The next kind of common tumor are the gliomas, and these gliomas these tumors arise from the supportive cells, these astrocytes that I mentioned earlier, and can be a very deadly kind of tumor. The worst of them are called glioblastomas, and there may be some unfortunate people out there that have known people that have had these terrible tumors. They are generally thought to be not curable, though we have had survivors. They're very bad lesions. Some of them they're not that malignant. The lower grade ones, for instance, the grade 1, people can often survive with those lesions. But these are the two most common. We have some uncommon tumors called sarcomas, and those tumors often they have a lymphoid connection. They can be associated. We have a big epidemic of them with AIDS patients. Not everyone with a sarcoma has AIDS, but they seem to be on the upswing. They can be a malignant tumor. They're They're somewhat between, in regards to their malignancy, between a meningioma and a glioblastoma. So they're kind of an intermediary kind of lesion. Now, probably the most common kind of lesion that we see are metastatic tumors. And I'm not at all wrong in saying this. I think that many people have known a relative or a loved one that had some kind of lung cancer or breast cancer, and the terminal event were metastases to different parts of the body, and we frequently see this in the brain. And this is a quite common kind of lesion, and we'll talk a little bit about how we deal with that and what sort of problems this causes. Next slide, please. So I'm just going to show you a few pictures of different kinds of brain tumors. These are scans, and the white lesion, I think we can see it abutting the skull. That's meningioma, and these lesions are generally slow growing, and they deform the brain. We can see the I don't think I have a pointer here, but I'll just depend on the audience being able to see what I'm talking about. The tumor is pushing into the parenchyma of the brain, the substance of the brain. It grows very slowly. This is a pretty good sized lesion here. And by its location, it is probably going to compromise this patient's visual field. This is the kind of lesion that's big enough and its location is a little bit threatening, then we would probably take this out. And this is the procedure for this would be surgery. The way we do this these days is that we employ sort of a fancy computer system to localize exactly where the tumor is. It's called a brain lab, and we do somewhat of a smaller procedure. And this tumor should shell out pretty easily. So with everything being equal, this is the kind of lesion we would consider doing something about, though we don't always. These tumors are often found in women, and they have hormonal receptors in them often, and sometimes they can be quite aggressive in growing. There are different ways we treat them when they're more aggressive. Not all of them are totally benign, but they generally are. Next slide, please. So just to show, I hope people can see where this sort of black space is in the brain. This is an astrocytoma. It's encompassing the patient's right frontal area. You can see it's a big lesion. And these lesions have different grades. There are 4 grades attached to the astrocytoma. This looks like a pretty big one. And this is the kind of case that we would probably consider removing it. The brain has 2 components to it. It's a so-called bicameral brain. It means there are 2 houses, the right and the left lobes. And I think what God did when he created the brain is he gave some redundancy. So if we can lose the front part of the brain on that side, and a person can be fine, because there's another frontal on the other side. I mean, I'll say fine in relative terms. I mean, I think people can be have quite normal lives with one frontal lobe. And so this is the kind of lesion that we would at least biopsy, and we would consider removing this surgically. If it is a low-grade glioma, meaning it's not very malignant, there are different things we do. Sometimes we radiate it, sometimes we don't. There's a debate about the appropriate thing to do, but these can be this is the kind of lesion that if it's a low grade, people can live with that for a long while. Next slide, please. And this, I'm not sure how well we can see this, but this is a brainstem glioma. And so if you look at the patient, this is a side view of a patient's brain. And if you go directly back from the nose, you see, I think we can see the nose, and we go right back to the we've got that. That's good. Someone is helping me. That's great. So we can see the brainstem, and in that brainstem we have a glioma. Now this is a slow-growing lesion, but the problem is its location. This is a very taxing, difficult kind of tumor to treat. because we can't surgically operate on this. It's not an encapsulated kind of lesion. We would damage the brain, the brainstem by doing this, and the brainstem is such an exquisitely important part of the brain that we can't do much with it. So all the fibers that go from your body to the brain pass through here, and the smallest injury here causes catastrophic neuronal deficits. Difficult problem to treat here, but these are the things that can afflict people. Next slide, please. And here we see, this is I guess once again, I wonder if we can put a little, I'm not sure how hard it's going to be to put our pointer. That's it, right there. Okay, that's good, thank you. You did well. So that's the cerebellum. That's the so-called hindbrain. This is the part of the brain that controls a lot of our fine coordination and movement. And we can see there that we have an abnormal picture on the scan on this MRI study. This is it proved to be an anaplastic astrocytoma grade 3. This is a very bad kind of tumor. We have 4 grades in these astrocytomas. They go between grade 1 and grade 4. But the real watershed is between grade 3 and grade 2. So even though this is a grade 3, the normal life expectancy with this kind of tumor would be only several years. And it's not the kind of lesion that we can surgically cure. Often we operate on this. We go in and we can take out a substantial part of the lesion. But the problem is it fades into normal neuronal tissue. We have different things that we try and do to control this kind of tumor, to treat it, but it's a very, once again, a very taxing thing to try and deal with. Right, next slide, please. So this is this is a glioblastoma, and let's see, can we once again put our little marker in there? There it is, that's good. This is, that's a very, very bad kind of tumor. This is the worst kind of tumor. It's a grade 4 glioblastoma. It's when people get this diagnosis, generally the life expectancy is in the nature of a year or 2. It is pretty much always fatal. So I use the word pretty much. I qualify it by saying that it's not always fatal. Sometimes there have been survivors, so we can always hope. Generally what we would do is we would go in this kind of lesion and debulk it. We try and take as much out as we could. We're not going to be able to do a total resection. And frequently we can say to a patient, we've taken out all the tumor that we can see. It's not there anymore. And we might follow this patient surgery up with a scan, and the scan will not show any obvious tumor. But the problem is with these kind of tumors, they follow the blood vessels into all different parts of the brain. So these tumor cells continue to be in often different, distant locations. And the problem with this is the doubling time is so rapid with this kind of lesion. So even if only a few cells are left, they go 2 to the 10th, 2 to the 3rd, 2 to the 4th. So they're making tremendous increases in their size very quickly. So even if we get a total resection, total gross resection, as we call it, we don't see any tumor left. The patient is still going to have tumor cells there. It's still going to be a difficult thing. We sometimes place in around the tumor bed, we sometimes put in different substances to see if we can kill the remaining kinds of tumor cells. Sometimes they're radioactive substances. Sometimes we use different kinds of chemotherapy that we actually place in the brain. People have tried everything you can think of to try and kill these cells. And we'll talk about some of the more experimental things that are on the horizon. They've tried freezing, they've tried heating, they've tried different kinds of substances, but they are really very difficult to defeat. Next slide, please. This is a sarcoma. I think we can see that. That's pretty much in evidence. And this lesion is near the motor strip on the right side, so the patient might be having some kind of difficulty with the left side of the body. Frequently, these tumors are associated with seizures. Sometimes people have seizures. They present with headaches, seizures, sometimes personality changes. And one of the interesting things about this lesion is we can see the white area around the tumor. And this is, that's cerebral edema that's turning up. That's an increase in the water in the brain. And this is referable to the blood-brain barrier being broken down. That's one of the biggest problems patients have. One of the great things that were discovered, I think, in the 1950s by one of my mentors, Dr. Galicic, at Sloan Kettering Hospital, New York City, is the idea of giving steroids to stabilize the blood-brain barrier and to prevent this swelling. So frequently, when we see this kind of problem, we put patients on steroids, and that can control the swelling and make them feel better. The issue is we finally get to a limit for how much Decadron or steroids we can give. The kind of treatment for this would be surgery, and we'd follow that up with different kinds of adjunctive treatment, such as radiation therapy. Next slide, please. Well, all right, just a quick picture. I think we can see this if we can put the pointer on the lesion. There we go. All right, that's an astrocyte, a medulloblastoma. And this is in a young person. We can see the patient looks a little younger. And this is right next to the brainstem. It's in the fourth ventricle. And this is the kind of lesion that formerly was pretty lethal. But I think these days we're doing better and better with medulloblastomas. And the cure would be a gross removal. So if we can go in and totally remove the medulloblastoma, a cure is possible. And so this is the kind of surgery we want to be extremely aggressive with in these young people because it's possible to cure them. We have to look out in this kind of case where sometimes the cells drop in the vertebral column and we get distant metastases. And we sometimes have to give a patient radiation to neural axis radiation, which can have some bad long-term impact. But for young people, this is what we need to do to cure this. Now, one of the most important things that's happened in medicine, and I think maybe people have heard some peripheral comments about it, is the human genome has been discovered and looked into, and so what's happening, the DNA analysis of these cells, these tumor cells, are being obtained these days. And it looks like we're picking up different kinds of medulloblastomas. Some of them are worse than others. So we're getting new diagnostic information. Some of them turn out to have a very bad genetic picture. And these cells, these tumors are not so curable. A different set of genetic signatures mean they could be curable. Next slide, please. All right, just moving along. We can see all the white dots in the brain. These are metastatic tumors. This is the kind of picture we see. It's very difficult to take all of these tumors out. We would sometimes do stereotactic radiation. Sometimes we'd give these patients chemotherapy. If there's a big lesion in a sensitive place, we will occasionally take the tumor out, particularly with a solitary tumor. And we can see the edema. If you can see around these white circles, there's some clear areas. That's where the brain is swelling because the blood-brain barrier has been broken down. Next slide, please. Right, so I'm going to move along pretty quickly. This is the way we diagnose these tumors. This is what your physician is going to do. He's going to look at the symptoms. We're going to ask if you had headaches, visual changes, seizures, any kind of localized neurological deficit. We'll do a physical exam. We'll see if we can pick up any neurological deficits. Then we'll do a variety of tests there. We do CT in the brain, we do CT scans, we do MRI studies. Both of these studies have been, in my career, have revolutionized the treatment of brain tumors. They really tell us what's going on. We sometimes do arteriograms. That's a study to see the blood vessels that go to the tumor to see what needs to be done. And we sometimes do molecular genetic studies, which gives us, if we can biopsy the tumor, we can get an idea of what kind of tumor we're dealing with and how susceptible we'll be to different kinds of treatment. Next slide, please. I'm going to move along quickly. These are the symptoms: bad headaches, vomiting, and we look at the patient's eyes. We can sometimes see abnormal eye findings, which I won't get much into tonight, but that's an important thing. Next slide, please. What we do is sometimes you'll see the patient the doctor look in the patient's eye. What we're doing is looking at the eye grounds to see if there's swelling in the retina, at the optic cup there. So if there's pressure inside the brain, it will be a visual. We can see it in when we look in the eye, and it's transmitted in this direction as we see. There's the brain, and the pressure is going into the eye, and we can pick it up. Next slide, please. Kind of hard to see it sometimes. Well, all right. This is a rather complicated picture here. I'm not sure we can see it that well, but I just what the point we want to make. And once again, I have my marker here on the left side. Just show us our left, right? Okay, right there. This is a glioblastoma that's just a de novo glioblastoma. It just appears, and these are the pictures of the different kinds of genetic abnormalities, the DNA abnormalities in that tumor. So sometimes these really bad tumors just appear. On the other side, on the right side here, we can see this is this different kinds of cells of origin. Sometimes these tumors arise, these very malignant ones, from ones less malignant. And my one comment I want to make is the very our top thing with our P53 marker here, the P53 genetic marker here. That turns out to be one of the most important defense mechanisms the body has against tumors. And I'll just make this comment. If the P53 is in some ways not working well, it's part of the way your body defends against cancer, then you're going to, the cancer can take over. So bad P53 is a bad thing. On the other hand, there's evidence that this P53, although it kills cancer, it also limits life expectancy. It's an interesting thing. So if you're going to live to be 300 years old, your P53 may allow your cells to live a long time, but they'll also allow the cancer cells to live a long time too if they appear. It's a pretty interesting thing. Next slide, please. Getting near the end. This is our normal treatment: surgery, chemotherapy, radiation therapy. Next slide. And we sometimes use a CyberKnife. This is just spectrographic stereotactic radiation. We give like big treatments, concentrated radiation to the tumor. Next slide, please. And this is the prognosis for patients. An older patient's not going to do as well generally. The functional status, we pay a lot of attention not just to how survivable the patient is, but how useful their life is. We go through and we do different kinds of tests on the tumor cells to see if they're bad or good in regards to histology. And we also look at the genetic markers. We'll have a quick chat about that. Next slide, please. Just one thing to remark upon, and I may ask, Sammy, you got a chance, I'm going to ask you a question in a second, okay? So one of the things we want to just say here is in the tumor cells themselves have their own genetic structure, and one of the tumor genes in the tumor cell is involved in resistance to chemotherapy. So if we can go in and suppress that suppress this MT gene, then with different kinds of treatment, then we can then hit the tumor with chemotherapy and kill the tumor. Right. Next slide, please. And this just shows how that works. Pretty busy slide. Next slide. And so now, Sammy, this is why you're here. Okay, you ready for these questions?
Yes, Dr. Rob.
What's the most common type of brain? Which of these types is uncommon? Did you get that, Sammy?
Yes, Dr. Robson. I think it's sarcoma.
You got it. All right, next slide, please. This is our second question. And which of these statements is true, Sammy?
Mm-hmm. Well, it's a very confusing question, but seems like the third choice is the right choice. Silencing of the MT gene has been associated with longer survival in patients with glioblastoma who receive alkylating.
You got it. You got it. Thank you, Sammy. You passed the test. All right, next slide, please. Now, just our final picture of Ted Kennedy, who died with a glioblastoma. Lots of progress out there. Senator Kennedy got some extra years, some new treatments. I hope that anybody in the audience that has a brain tumor will not give up hope. We'll fight against it. Medical science is making tremendous strides, and we hope to do better in the future. And so thank you for watching, and thank you for being here tonight,
Thank
Sammy.
you, Dr. Ross.
We'll talk some more about this. Thank you.
This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.